All right. Can you all hear me okay? Great. Thanks so much. It's really a pleasure to be here. I think all three of us are really excited about giving this talk today. Hopefully it'll stimulate some good discussion about how we can think about the next generation of therapies for all of our cardiovascular patients. So quickly, our disclosures, I will not read them all out to you, but I will say that I think it's great that we're all talking with the industry leaders that are pushing these therapies forward so we can bring more information to you about how they're thinking about this as well. So there are many reasons why genetic cardiovascular disease is actually well suited for what we're going to call gene therapy today. When we think about who's a good candidate for gene therapy, we think about several different sort of characteristics of that patient that I think as we go through the list, you'll be convinced are definitely true for many of our cardiovascular diseases. So diseases with high morbidity and mortality, right? We've got MI, we've got heart failure, we've got arrhythmias that we can't necessarily treat effectively with current therapies. Diseases with suboptimal therapies. So certainly we have GDMT for heart failure, but as we all know, we also need to do heart transplants because those therapies are not adequate for the entirety of the population. We know that we have patients that require multiple PCIs, multiple interventions because they continue to have MI despite being on maximal therapies. So in our population, there's definitely a large subset of patients that's undertreated, even though cardiovascular disease is probably one of the best funded for curing disease in our patients. Diseases with a high individual and familial burden. So I think when we hear gene therapy, we think about fixing sort of what we call monogenic disease. But what's important about that is that for those families and for those patients, they've inherited something. We may not know enough of how they can modify their lifestyle. We may not have a drug for it. And so they're walking around with a fear of dying suddenly. They're walking around with the fear of needing a heart transplant. And so if we were able to offer them a therapy early in their life that could reverse the course of that disease, that would have a humongous impact on the lives of both that proband, that patient, and their family members. And then again, diseases that affect the young or start to decline at an early age, if we can intervene before that happens, we could really change the course of someone's life. And then lastly, and this is really critical, I think, for a couple of the examples we're going to talk about today, is that we often know some part of the underlying mechanism, but we don't have a small molecule, or we don't have a way to get that small molecule to the tissue type that needs it in order to actually affect change in that mechanism. And so as you'll see today, gene therapy actually offers a way to get where that needs to go and to express some sort of molecule or protein or inhibitor of what needs to be there to reverse the mechanism of that disease in a way that we can't do currently. So just to take a step back, because again, when we think about gene therapy, I think we often think immediately about sort of ultra rare genetic disease, right? We have the amazing Center for Undiagnosed Diseases here that you and Ashley and Matt Wheeler have run for a long time. We think about gene therapies for, kids with, for example, spinal muscular atrophy as sort of these N of 1 cases. But it turns out that genetic or inherited cardiovascular disease affects a much broader swath of the population than we generally think about. So the first example is highlighted by this. Oh, I don't think I have a pointer here, do I? Nope. Okay. It's highlighted by this graph here, which shows basically these blue dots represent variants or changes or misspellings in the genome or the genetic code. And the idea is that if you look at the population prevalence of any one of those variants, the more common that those variants are, the less size or effect size that they're going to have on the disease for that patient, right? Because there's a selection pressure against variants in the genome that cause really significant disease. And so as you move this way on the population prevalence, where you get to very rare variants, we're going to expect them potentially to have a very large effect size on disease. The reason that I'm pointing out this cluster of variants here first is that these are common variants. So the type of variants that are picked up in, for example, GWAS studies, the type of variants that are included in polygenic risk scores. And it turns out that if you add up a bunch of those variants, which because they're common, many patients will carry a bunch of them, they can have risks of disease that are higher than a single monogenic rare variant at the other side of the spectrum. And the disease we're going to talk about today, in particular hyperlipidemias, can really be affected by changing a single gene in order to treat a risk that comes from many variants. And then on the monogenic side, those diseases aren't as rare as we think either. So familial hypercholesterolemia, 1 in 200 patients. Hypertrophic cardiomyopathy, 1 in 500 patients. Kevin will tell you that a large percentage of patients with HFpEF actually have ATTR, right? They actually have an amyloid cardiomyopathy that now has therapies and will in future have definitive therapies that he'll tell you about. So we actually are, we're addressing a really large portion of the population here by looking at genetic disease as a whole. And then lastly, even in those numbers, we're likely missing patients who have those genetic diseases. This is some data from Dan Rader's group that was led by a really fantastic medical student, Joe Park, that shows that if you look for variants, for example, in the gene lamin AC, if you look for variants that disrupt the function of that gene, which causes a really severe dilated cardiomyopathy, you will find that they actually exist at a higher rate in a biobank, which is unselected than you would think, and that they are associated with pretty severe phenotypes that were not classified necessarily as a lamin dilated cardiomyopathy. So there's even a population of patients that we're missing that could be addressed by gene therapy. So we're going to talk about multiple modalities of changing or using the genome in order to treat these diseases today. I did want to spend a little bit of time talking about gene editing, which is actually getting to the genome and changing its code and where that technology came from. So these 2 Nobel laureates, Jennifer Doudna and Emmanuelle Charpentier, got the Nobel Prize in Chemistry in 2020 for this technology, which you will have heard of, called CRISPR-Cas9. So what is CRISPR-Cas9? These images are from a beautiful video on the MIT McGovern Institute YouTube channel. And what they show is that you have this protein here, which is this blue blob. It's almost like Pac-Man's facing you, right? It's got a circle with an open mouth. Do the fellows remember Pac-Man? Okay, good, just checking. I think there's like some 90s recrudescence. Anyway, so that Pac-Man is holding in its mouth this little piece of single-stranded nucleotide, which is like a zip code. And that tells Pac-Man where to go in the genome. That genomic sequence then binds to the patient's DNA, and then it can break that DNA in half, and it actually uses the DNA repair machinery that's already in the cell to rebuild that section of the genome. Now, this is amazing, right? That we could actually use this to go in and change the genetic code, to change what we have often referred to as the blueprint, right, for who we are and the diseases that we have. It's important to note that this particular technology itself, because it breaks the DNA at both strands and because it relies on imprecise repair machinery, is not going to give us the precision that we need to go in and change a variant that we know is actually causative of disease. But it can certainly break a protein if we need to get rid of it. So we have CRISPR-Cas9, which we talked about. This is really good for double-stranded breaks. It has variable efficiency in targeting, but you can use it to break a gene that you don't want to be there anymore. Really amazing work from David Louie's lab, took Cas9, made it unable to make that double-stranded break, and then added another molecule to it that can change the chemistry of a specific base. So now you can go in and without actually sort of activating this double-stranded DNA repair machinery, which is really imprecise, you can go in and actually precisely say, I want to change this A to a T, right? I want to change this G to a T. And then you can rewrite the genetic code that way. Now, it's important to note that these aren't perfectly precise. They can make these bystander edits at different sort of positions that are nearby. But this is much closer to a safer technology that could be used to rewrite the genomes of our patients. And then there are other derivatives of the Cas9 system. For example, you can turn on or turn off a gene with CRISPR inhibitors and activators. And then this really cool one up here called prime editing actually takes a template that you give it. It has what's called a reverse transcriptase on it. So it takes that zip code that all of these have, it finds the spot in the genome, search function, right? Control F, right? Find. And then it rewrites it. So it's like a search and replace function for the genome. That's pretty cool. Of course, it's pretty inefficient right now. It's also a huge molecule, that's a little bit difficult to deliver, but it's really exciting technology that may actually enable us to precisely edit genomes in a way we haven't before. So how do we get from this technology to therapy for our patients? What can be done? We can replace a missing gene. So if we've got a variant, for example, that breaks a copy of a gene, we can give back a construct that then expresses that gene. We can disrupt a misbehaving gene. For example, you could break it with CRISPR-Cas9. You can edit a variant back to reference sequence. That's what I talked about with the base editors or potentially prime editing in the future. And you can also turn on or turn off a regulator, either by breaking it, as we mentioned, or by expressing some protein that you have trouble delivering to that tissue in some other way. So that's pretty cool. But why aren't we there yet, right? We're partially there, and you're going to hear about that for multiple diseases today, but there are challenges with the applications of these technologies to therapy. So the first thing is that editing efficiency. We want to make sure that we can actually do what we're trying to do in a way that's going to, affect enough cells in the tissue of interest to see a change. There are those off-target effects and bystander edits. You may have seen that the FDA talked about this with several companies that are doing gene editing in the last couple of weeks, and making sure that we're not creating breaks or edits where we don't want to elsewhere in the genome. And then the big one is delivery. How do we get these constructs where we want them to go? So that includes getting the payload, which is whatever genetic information you're delivering to that cell, to the right place and in the right amount. You don't want to overload the cell with that, but you also want to make sure that you've got enough of it to make a change. So with respect to that, and this is going to come up over and over again in the talk, there are some big issues. The first is tissue specificity. You want to deliver to the tissue you're trying to get to. If I've got a problem with the gene that's expressed in the heart, I've got to get my therapy to the heart, right? If I've got a problem with a gene that's expressed in the liver, I've got to get that therapy to the liver. So it turns out that there are some ways to deliver specifically to different organs. This is a 3D structure of an adeno-associated virus, an AAV. Different serotypes of these viruses have different tissue specificities. The one we use for cardiac muscle and skeletal muscle mostly is AAV9. You'll hear about that today. You can also, because there are problems with this AAV we're going to talk about in a second, use something called a lipid nanoparticle, where you encapsulate that information in this nanoparticle and you deliver it to the liver. There are folks who are working on targeting these to specific tissues, but that is not certainly not being in trials yet. But you'll hear about lipid nanoparticles from both Josh and Kevin today. Issues with AAVs is that you can't fit that much DNA in here. So you can only get about 5.5 thousand base pairs. Many of the technologies we're talking about are 14,000 base pairs. So you have to find a way to glue it back together. That adds a level of inefficiency. And then additionally, they cause this problem, which is immune activation. We're going to talk about this extensively. I think you probably saw the New England Journal article regarding the patient that was a Duchenne muscular dystrophy patient. We'll go over that in detail, but the idea here is that AAV can only be given once because you're going to develop antibodies to it. It already has some toxicity. It can cause thrombotic microangiopathies, which is similar to hemolytic uremic syndrome. And then it turns out that you can also have an immune response to the payload. So many of us have antibodies to CRISPR-Cas9 already. And you can get side effects from the immune suppression that we're giving with these therapies. For example, skeletal myopathy, to try to reduce that immune activation. So these are challenges we're going to talk about over the course of the talk today, but they are addressable. And it's actually really exciting the way that people are doing it. So with that, here's our outline. Josh is going to talk about gene therapy for lipid syndromes. Kevin's going to talk about gene therapy for amyloidosis. I'm going to tell you a little bit about what's been done for cardiomyopathies, and then we'll end with a look to the future.
Thank you for that wonderful introduction to the topic, Vicki. It's a great pleasure to be here with two of my favorite people. I know that we're missing many of our colleagues who are already at the American Heart Association meeting, and I suspect that by the end of that meeting, some of what we say will be outdated because this is going to be a hot topic there as well. So I'm going to talk about gene therapy for familial hypercholesterolemia and other lipid disorders. And it turns out gene therapy for lipid disorders is already happening. It depends on how you define a lipid disorder. And this has been going on for a long time. But these are some of you just search clinicaltrials.gov, you'll see a lot of gene therapy trials mentioned for very rare genetic disorders that largely affect the neurological system, Tay-Sachs disease. These are glycogen storage disorders and other things. But that's really not what I'm going to be talking about, which is more focused on cardiovascular disease. There have been a few gene therapy trials in pure lipid disorders like we think about, and I'll talk about those throughout the talk. One for people with extremely high triglycerides and others for familial hypercholesterolemia that have had some problems, and we'll talk about why. And but I think the landscape is really changing with these new technologies, which is what we really want to get into. And specifically, we're hopefully going to start enrolling in a trial for familial hypercholesterolemia very soon that I'll come to towards the end. So some would say that familial hypercholesterolemia was really the first use of gene therapy. And in this case, gene therapy was liver transplantation, because if you can correct the gene in the liver, you can greatly ameliorate the problems with familial hypercholesterolemia. And this is a slide from a former member of our lab who's here for a year, Grosley, who published this great paper about individuals that had undergone liver transplantation for homozygous familial hypercholesterolemia and showed dramatic reductions in their cholesterol levels over the years. Of course, this is a really a dramatic way of treating something like this, but it is still very rarely done, occasionally done. So there's the mic drop for that. So, but really, when we're thinking about the modern era, we're thinking about gene therapy. I think there's really a critical decision or a critical thing that you have to decide. Are you going to try to restore or repair the function of DNA, or are you going to try to knock out or silence DNA? And if you're going to try to restore or repair DNA, I think it's really important to understand you do not have to restore or repair 100% of the genetic function to make a huge difference. Sometimes only 2 or 3% of the function of the gene needs to be restored to have a dramatic effect. However, giving a gene back, as Vicky talked about, often requires a very large payload, and that is quite complicated, and we have not yet been successful at this kind of strategy in lipid disorders. It's much easier to break a protein or to inhibit a protein or to make it non-functional. And there's some really good targets for that, such as PCSK9, ApoC3, ANGPTL3, ApoB, and lipoprotein A. And we'll talk about those some of those specific test cases. So that's one critical decision. Now, this is all built on other work that's ongoing that has not required such dramatic interventions as gene editing or gene therapy, but many definitions of genetic therapy would include several therapies that are already on the market or in late-stage clinical trials for blocking mRNA translation. And here are some of those targets that I talked about before. ApoB, there are drugs available. If you decrease ApoB, you decrease LDL cholesterol levels. If you decrease PCSK9, you decrease LDL levels. There are drug therapies already. Inclisiran is already available in our clinic. It silences PCSK9. And so the companies that are doing the gene therapy are looking at what came before them and said, what's working? Can we do it better? ApoC3 decreases lead to massive decreases in triglyceride levels. Lipoprotein A, lowering targets. We talked about lipoprotein A at Grand Rounds a few weeks ago. And there are 3 great drugs that are in clinical trials now. And ANGPTL3, I'll come back to this in a little while, but decreasing ANGPTL3 dramatically lowers both LDL and triglyceride levels. Antibodies to address this are already available in the clinic for homozygous FH patients. And there are silencing approaches that are also looking very promising, and I'll mention them briefly later. So there are lots of these therapies that are either available or ongoing, and I think that the companies that are developing gene therapy are very aware of these, both in a positive and negative way. They're saying, yes, if we treat this target, we're likely to have success, but also that's going to be competition. So that also has to be mentioned. So one of these, of course, is PCSK9. PCSK9 inhibitors are very successful in lowering cholesterol level. The antibodies have been available for 7 or 8 years now. Inclisiran is a siRNA inhibitor. It's been approved and is now available in our clinic, largely thanks to ABBA and others. And we're giving this to patients who really seem to like it. It lowers LDL cholesterol dramatically. And so we'll talk about gene editing for PCSK9 in a second. True gene therapy, where you actually give a gene back to a patient, has been harder. Like Vicky said, delivering AAVs, delivering the genes to the right tissue has proven to be a challenge. And so far, true gene therapy, giving a gene back for lipid disorders, has not worked well. There was a trial in homozygous FH patients with an AAV-mediated approach, and it was done as a proof of principle, but it suffered a lot of difficulties, and it has been sort of abandoned. There was also a gene therapy that was approved in Europe, never made it to the US, to replace lipoprotein lipase, and it was withdrawn from the market because it was very, very, very expensive, and it was not thought to be a useful therapy. So but the landscape has now changed. Vicky introduced this idea of CRISPR gene editing and base editing. And as she said, there's the scissors approach, where you remove, you create a double-strand break and you completely knock out the gene over here. But what we're really talking about in lipid disorders, and what we're most excited about, is a more targeted approach where a specific base editing technology can be used, CRISPR base editing, where a specific nucleotide is changed to another nucleotide, more like a pencil and eraser. And it's thought that this will be both more effective potentially, and also potentially less toxic. So the next question is, how do we deliver the package to the liver? For lipid disorders, that's the key organ, and not to other tissues. We know that for hemophilia and other bloodborne diseases, ex vivo therapy is possible. You can take the bone marrow out, you can alter it, you can put it back in to the patient, but that's not going to be likely to work for lipid disorders. So really, we need to target the liver. Luckily for us that are interested in lipid disorders, the liver is an easy organ to target. It is at any one time, it's taking up 10 or 15% of the blood volume. There's hundreds of monogenic metabolic disorders, so it's a ripe area to target. It's amenable to in vivo rather than ex vivo approaches, and again, you can target it with packages that are delivered by adeno-associated viruses, or actually, which is probably going to be more useful and more readily available, lipid nanoparticles. Now, and that's the approach that we're going to be talking about mostly, delivering the gene editing with a lipid nanoparticle. Now, it's important to realize that these lipid nanoparticles bind the LDL receptor, and that has some implications for what we're talking about. And these are a lot of examples of liver-targeted gene therapy trials that are already ongoing, or phase 1, phase 2 trials. So a lot of diseases, a lot of interest in this, and we'll be hearing more about this. Vicky is going to cover this case here, where adeno-associated virus led to a death of a muscular dystrophy patient. So how is this working, and how well is this working, and why are we so excited about this? And this is work that was done in base editing in monkeys, in non-human primate models. If you knock out or edit PCSK9, if you edit PCSK9 to make it non-functional, you can knock this out in non-human primate monkey models. You dramatically lower the protein level, and it dramatically lowers the LDL cholesterol level. And this is after a single dose, and you can see that the effects are long-lasting. And there's now data for much longer than this, up to 600 days, that if you edit the PCSK9 in the liver, that edit persists in those liver cells. It's passed on to the resulting cells. And so it's a stable knockout, and it looks to be very promising. And these are data that are publicly available. So now you can see that LDL cholesterol levels by this gene editing are knocked out for over 600 days. And what are the major potential concerns, off-target effects? Do we affect innocent bystander genes? Is there germline transmission? Is it going to go to the testes or the ovaries? Are there side effects of the delivery systems, and how long will the effects last? And the FDA had some of these same questions, and they required the companies to go back and say, are we experiencing editing? Is there mutations that are being created in places that there shouldn't be mutations? And they forced the company to do a lot of digging into that. And so far, we have not found a lot of evidence that there's off-target gene editing effects. We have to remember that every time we give a cancer chemotherapeutic agent, we're going to be editing, we're going to be creating a lot of mutations. So this looks, potentially pretty reasonable. And the FDA was at least satisfied enough by this that about 2 weeks ago, they allowed Verve to start the process to do this trial in the United States. They've already been doing it in New Zealand and the UK. So we've been selected as one of the sites for this Verve trial, and hopefully we'll be enrolling in 2024. Heterozygous FH patients, severely affected heterozygous FH patients. And so if you have any such patients, please think of us. Now, this is not going to be the cure for everybody, and this is a very poignant story of a girl, and her parents are heavily involved in the Family Heart Foundation. She has homozygous FH. At age 6, she required open heart surgery to repair her aortic valve, which had been damaged because she had LDL cholesterol levels in the 600s or 800s. She has to go undergo apheresis, and the current Verve strategy will not really work for her very well. So because the lipid nanoparticles normally bind the LDL receptor, and she doesn't have any functional LDL receptor. So how are we going to get around that? And so there's other technologies that are in development to target the delivery of the payload to a different receptor that does not require the LDL receptor. And those therapies look quite good. And the gene that they're going to be delivering is ANGPTL3. So ANGPTL3 is another lipid-lowering molecule. If you knock it down, either with an antibody or with RNA interference, you have dramatic effects on LDL cholesterol. Here's the antibody data in FH patients. And here's a paper that I was even on, where we used a clinical trial to knock down ANGPTL3 using RNA interference strategies. So it's a viable target. And this is going to be used in homozygous FH patients, hopefully in the future, delivering ANGPTL3 gene editing payloads to knock this out in liver and thereby allow us to treat homozygous FH patients. So in summary, there's many morbid lipid conditions with suboptimal treatments. We know that there are great targets and have been approached with RNA silencing, and DNA-based gene therapy and gene editing have really great promise. So I'm going to turn it over now to Kevin to continue the theme.
Great. Can everyone hear me? Yeah, so to go over another disease area where gene therapy is going to emerge as a potential therapeutic class for treatment is transthyretin cardiac amyloidosis. And the treatment landscape for this disease has evolved a lot in the last several years. And so I'll kind of give an overview of that and where potentially gene therapies fit in that. So it's increasingly clear that transthyretin cardiac amyloidosis is not as rare as previously thought. As Vicky alluded to, there's many patients with heart failure with preserved ejection fraction that indeed have ATTR cardiac amyloidosis. People with low flow, low gradient aortic stenosis, there's been studies to show an association. Patients with hypertrophic cardiomyopathy, some of those, a subset of those actually have underlying cardiac amyloid. And we incidentally find this on a number of non-cardiac tests for scintigraphy. And so really the two subtypes of transthyretin cardiac amyloidosis are wild type, where a normal copy of the protein breaks down. And this is a disease associated with aging, male predominance, and is the big driver, HFpEF, of the ATTR subtypes. And it's mostly cardiac involvement. There are people that have a hereditary form of this disease or variant ATTR amyloidosis, where they have a point mutation or one or both copies of ATTR that increases the predisposition for developing amyloid. And this can have an earlier age of onset, and also more rapidly progressive and more heterogeneity in terms of organ manifestations, neuropathy, as well as cardiomyopathy. To understand the treatments that are currently available and where gene therapies might fit into this, I'm just going to review the pathogenesis briefly. So transthyretin is a protein produced in the liver. Its normal function is to transport thyroid hormone, vitamin A throughout the body. When it's secreted, its native form is a homotetramer, four like pieces associated closely together. And when these dissociate through a variety of mechanisms, some are poorly better understood than others, these are thermodynamically unstable. And these monomers start to misfold and aggregate to form these long rods of proteins, which are the amyloid. So for cardiac ATTR, we have one FDA-approved therapy that works through this mechanism of stabilization of transthyretin. So this is a small molecule that binds to the tetramer to help reduce the fraction that breaks down to form those unstable monomers that form amyloid. The drug that's been FDA-approved is tafamidis. Acoramidis is another stabilizer in a class that just had phase 3 data that read out at ESC back in August. So the TRACK trial that looked at tafamidis, this was a phase 3 study, over 400 patients that had either wild type or hereditary ATTR, had class 1 to 3 heart failure, and randomized to one of two doses of tafamidis versus placebo and traditional cardiovascular endpoints. This was a positive study for the primary endpoint of mortality and cardiovascular hospitalizations. If you look at the subgroup analysis, the main group that didn't show benefit was the class 3 heart failure patients. And I think it highlights the fact that while we do have a treatment that improves survival, there's still a lot of unmet need, particularly for people that have advanced disease, such as those with class 3 heart failure. So the other class that's been studied extensively are the transthyretin silencers. So like Josh alluded to, for diseases that have liver as a source, this is a very druggable organ. And so that's the case with ATTR. Even though it's a cardiac disease, the source of the amyloid production is the liver. And so that's been where a lot of targets have been developed for therapies. So I'll go through some of these drugs. These are siRNAs and antisense oligonucleotides that decrease the expression of transthyretin in the liver. So the first study, phase 3 study that led to the approval of an siRNA called patisiran was the Apollo study. Looked at over a couple hundred patients. Of note, this is a neuropathy trial. So the only trial that's led to FDA approval for cardiomyopathy to date was tafamidis. A lot of the other trials to date have looked at polyneuropathy. And so this drug is an IV infusion given every 3 weeks. And the primary endpoint is this mNIS+7 score, which is a composite score of various neuropathy components, so autonomic, sensory, and motor neuropathy. So higher scores, more neuropathic deficits. So this was the primary endpoint. You can see in the placebo group over 18 months, the mNIS+7 score worsened by 28 points. And as a frame of reference, if you think about something like diabetic neuropathy, you might expect that that's, if you have poorly controlled diabetes, to have a mNIS+7 change of maybe a few points over a year. So 28 is really, shows how devastating this neuropathy can be from ATTR. Over a year or two, people can go from walking ambulatory to cane or walker, or from walker to wheelchair bound. When we look at the patisiran group, not only did the neuropathy impairment stabilize, but there was actually improvement in the score of about 6 points. And so these wildly positive data led to approval of this drug for ATTR neuropathy. There's a next generation of the siRNA, vutrisiran, which instead of being given intravenously weekly, or every 3 weeks, is given subcutaneously every 3 months. And so this Helios A study looked at vutrisiran compared to the historic Apollo control and showed that it similarly is effective at halting the progression of neuropathy. If we look at the knockdown of transthyretin for both patisiran and vutrisiran, it's around 80 to 85%, and you can see that that knockdown is pretty rapid and sustained over time. Antisense oligonucleotides have also been looked at for ATTR neuropathy. This was a NEURO-TTR trial that came out around the same time as Apollo, very similar study design, and looked at the mNIS+7 endpoint. And so you see a similar worsening in the placebo group. In the treatment group, there was there was definitely a clear difference, but not quite as dramatic as what we saw for patisiran. Patients on inotersen did have progression, but it was markedly blunted compared to placebo. The next generation of inotersen is eplontersen, which is also subcutaneous like inotersen, but it's given monthly instead of every week. And you can see that there's good data from the Neurotransform trial, and knockdown with eplontersen in that 80% range. So what data do we have for cardiac amyloidosis with the silencers? Really, the only trial to date is the Apollo B trial that resulted last year. This looked at 360 patients, and the primary endpoint in this study was a 6-minute walk test. So it wasn't powered for mortality and CV hospitalizations like ATTRACT was. They did meet their primary endpoint. They showed a 14-meter difference in 6-minute walk at a year, but there wasn't power to show differences in hospitalizations and mortality. So the current landscape in terms of therapies that are FDA approved now, tafamidis is the only drug approved for cardiomyopathy. If you have hereditary ATTR neuropathy, then there's several: patisiran, inotersen, vutrisiran. Based on the Apollo B data, Alnylam tried to get a label extension for cardiomyopathy, but were unsuccessful, mainly just based on the strength of the data of only having that 6-minute walk difference. So, you've probably saw this in New England Journal a couple of years ago. So CRISPR-Cas9 has made it into the ATTR space. This was a phase 1 trial of NTLA-2001 produced by Intellia. This was also studied in neuropathy patients in the UK and New Zealand. Apparently, those are places to study gene therapies. And so this is an LPN-based delivery, so it kind of doesn't have so similar delivery to some of the siRNAs that have been studied, and so avoiding the potential toxicities to AAVs. And so in that study, dose escalation study, you can see at the higher doses, very good knockdown of transthyretin, actually probably a little bit more than what we saw for the silencer. So instead of 85%, greater than 90% we're seeing in this phase 1. When this story came out, there was a New England Journal, NPR piece that came out, and I have to say probably a dozen patients reached out to me after this asking when they could get their genome edited for transthyretin, which I thought was kind of interesting that people would jump on that. So I think that at least in the amyloid space, there's a lot of interest in emerging therapies, including gene editing. So, the current landscape, there's other ATTR trials ongoing. The silencers that were studied in neuropathy or in cardiomyopathy trials, we're participating in those at Stanford. There's other therapeutic classes, monoclonal antibodies, to see if they can bind to amyloid and remove it. But suffice to say that this is a rapidly evolving space with multiple drug therapies and exciting time. So in summary, TTR knockdown is what has been well established for treating ATTR polyneuropathy. There's trials ongoing to look at its effect in treating cardiomyopathy, but I suspect, given the common mechanism of action, that there's going to be a good clinical effect. And based on that, I think that it lays a lot of groundwork for gene editing in this disease, because we know that lowering transthyretin leads to these benefits. So one would think that if you're able to knock it down with gene editing, that we should see similar, if not better effects. I think the question of, is greater knockdown with gene editing, does that lead to added clinical benefit? Will be interesting to see in the phase 3 trial for the CRISPR product. I think that there's still a lot of unanswered questions about long-term safety. In terms of lowering transthyretin, are there any untoward consequences of that? And so that's something that I think we'll need to have more data on. And given that we have several therapies available and other ones down the pipe, say gene editing is shown to be effective, where would its place be in the treatment landscape? Certainly cost would be a big factor, as well as patient-specific characteristics. I don't think it's a one-size-fits-all that everyone would get, and so I think that'll be interesting to see how that develops. So with that, I'll turn it over to Vicky.
Thank you, Kevin. All right, so we have, I think, about 17 minutes left, and there's maybe at a point of information overload. How's everybody doing? Feel like you know how to treat all these diseases with gene editing at this point? Yeah, okay. All right, so I'm gonna I'm going to go fairly quickly through the gene therapy for cardiomyopathies and focus on the fact that these are being delivered with AAVs rather than the LNPs that we just heard about from Josh and Kevin. So here, when I talk about gene therapy, I'm going to be referring specifically to gene replacement therapy. We're going to talk today about Danon disease, which is a nice sort of poster child for being able to treat genetic cardiomyopathies. Here, we're not talking about using CRISPR-Cas9 or any of its derivatives. What we're talking about is taking a construct, which is this purple arrow here, that encodes a missing gene. So here it will be LAMP2 for Danon disease, putting it into an AAV because it fits. It's smaller than that 5.5 thousand base pair size, and then expressing it in heart tissue using that tissue-specific AAV9. So here we're going to start with not enough of protein X, which is going to be LAMP2 for Danon disease. We're going to deliver that construct with the AAV specifically to the heart. Here we're delivering DNA. You can also deliver RNA, potentially proteins and LNPs. We need to know that we delivered enough of that protein. We affected enough cardiomyocytes, and also we got enough of that protein expressed in those cardiomyocytes in order to actually correct the disease. So here, Danon, briefly, as you may remember, is a rare genetic cause of hypertrophy in the myocardium, which can be classified as hypertrophic cardiomyopathy, although not the same mechanism as a sarcomeric hypertrophic cardiomyopathy. Here, we're actually getting buildup of glycogen and other vacuoles that are going to make the myocardium thick. So that's due to this loss of function in this gene LAMP2, which controls autophagy in the cardiomyocyte. This disease is X-linked. It turns out that both male and female patients who have a LAMP2 variant can get disease, but as you can see over here, you're going to have this rapid decline in survival in males between the ages of about 10 and 30, whereas females have a later onset of disease. And it's also associated with skeletal myopathy, developmental delay, and retinopathy. So this is the first sort of success story, I think, of using gene therapy in cardiomyopathies. This is the paper that showed that this could work in mice, where they used this AAV9 carrying LAMP2 on mice that were a model of Danon disease, and they saw improvements in survival, as well as this vacuolization, which is an effect of the disease, which you can see in electron microscopy in the myocardium. They did this at several doses, both in adolescent mice and in adult mice, to show improvement. So this led to a first-in-humans trial. This abstract was published in 2022 at AHA. There was an earlier one in 2021. The idea here was that we were going to deliver this AAV9 containing LAMP2 to patients with Danon disease, specifically as a phase 1 non-randomized open label trial. IV, so intravenous AAV9 delivered for the full length of LAMP2B. These doses were the two doses that were tried. 10 to the 14th viral genomes per kilogram is a relatively high dose, and then 10 to the 13th, of course, 10 times less than that. Immune suppression was used with this in order to anticipate the body's reaction to the AAV9 delivery. This had been seen in other diseases, specifically with rituximab for the high-dose group, as well as pediatric patients, prednisone and tacrolimus or sirolimus in the pediatric population. Inclusion criteria was that they had to be male because of that nice short window that they could look for actual improvement in symptoms and biomarkers, and that they had to be quite sick. So NYHA class 2 or 3 with cardiac involvement by EKG or echo. And then if you had an anti-AAV9 antibody that was going to therefore cause you to have an immune response to this, you were excluded. And then additionally, sort of severe disease was excluded as well, just given the precipitous decline of these patients. So there were 5 adults or adolescents that were enrolled and 2 pediatric for this. You can see here what the immune regimen was. I don't want to spend too much time on this except to say that there was a grade 4 TMA response in one of the patients that received the high dose therapy. And so then that dose was discontinued in the trial. TMA is that thrombotic microangiopathy, which is an HUS type syndrome. They also saw steroid myopathy in this group with escalating doses of prednisone, but actually found that with a low dose in the pediatric population, they didn't have significant adverse events, and that both patients had normal platelets on delivery, which are a sign of that TMA response. They showed that in the myocardium of these patients, there was expression of the LAMP2 vector by doing biopsies, which was really encouraging that the therapy at least was doing what it was supposed to at the level of expressing that gene. And then they compared the treatment group to a natural history cohort here on the right. And what you can see is that this is BNP levels, but the same was true actually for KCCQ and other markers of fitness, that you had this stabilization to improvement of these with delivery of LAMP2 here as compared to worsening BNP symptoms, et cetera, in the natural history cohort. So overall, very encouraging data, but with the TMA event and with other adverse events of needing to give immune suppression, of course, cautionary with respect to how we're designing these trials as we deliver these medications, these gene therapies. I do want to point out here that Danon may be an ideal myocardial disease to start with. It's one that's got no intrinsic expression of the protein of interest, and the protein is small. So you can actually use a gene replacement strategy here in order to treat these patients. The risk to potential benefit is high. You saw that precipitous decline, especially in male patients. There's this Goldilocks window, which means that they're starting to get disease, right? You know that disease is going to decline precipitously, and you don't have to follow them very long in this clinical trial to see the improvement versus natural history progression. And then lastly, there's high penetrance, which means that if you're giving the drug to somebody who's starting to develop disease, you believe that they're going to have that same course of action, and so the potential benefit remains high. So I'm just going to skip here because we're running out of time a little bit to show you the other cardiomyopathies that are being developed actually for gene therapies. There is a PP1 inhibitor that is in phase 1 right now that is for all non-ischemic cardiomyopathies. We're actually considering being involved in the phase 2 of that trial. There's also a MYBPC3 replacement for HCM. That's from a couple of different entities. And then also a couple of different industry partners are interested in treating ARVC with plakophilin 2 replacement. So this is a very active area. And I think that figuring out how we're going to address these potential pitfalls with the AAV delivery and immune activation is going to be really critical. So I did want to talk about that case that Josh brought up, which many of you may have seen came out in the journal, New England Journal this year. So this was a 26-year-old patient that had progressive Duchenne's muscular dystrophy. The patient was non-ambulatory, did have a preserved ejection fraction, but also had pretty bad lung function due to skeletal muscle weakness. In this trial, they were actually giving basically a CRISPR activation construct, which that was meant to actually turn on a gene that could help with DMD. They pre-treated with rituximab, glucocorticoids, and sirolimus ahead of giving the AAV9 to deliver this gene therapy. On day 0, remember, this is a relatively high dose, 1 × 10⁻⁴ viral grams per kilogram was given. And what you can see is that between day 0 and day 8, there was this progressive worsening where the patient first dropped their platelets. They had some evidence of complement activation similar to TMA, so they were given eculizumab at that time, started to have worsening pulmonary function. LVEF dropped to 45% with a pericardial effusion. And eventually, the patient progressed to ARDS, cardiac arrest, ECMO, coma, and death. It's important to note that during days 3 to 6 here, there was a massive escalation in immune modulation regimen. So they escalated glucocorticoids. They gave the eculizumab, as I mentioned. They gave tocilizumab as an anti-IL-6R and anakinra, which is anti-IL-1R. So what we're looking at here is a progressive very severe response to this AAV, but it's not clear exactly what happened because the patient certainly had their immune system extremely suppressed. So importantly, there was a high dose of AAV9 given, but not all patients have adverse reactions at that dose. There was no complement deposition on autopsy, indicating that this was not just TMA that had gone out of control, but there was a high viral genome load in the patient's lungs. Immune suppression was administered, as I mentioned, and aggressively uptitrated. And so the authors came to the conclusion that likely this was a cytokine-mediated capillary leak response due to an innate immune reaction to the AAV, which is going to be different than specific antibodies to AAV, which they would have ruled out beforehand. Could the patient's advanced stage of disease have contributed? So this is another Goldilocks problem. Is the patient sick enough to get a high risk, potentially high risk novel therapy with an AAV, or is the patient too sick, right? Is that, are the patient's lungs so progressive, progressed in disease, or the skeletal muscle, skeletal myopathy so progressive, they're not going to be able to handle any sort of innate immune reaction to that AAV? And then what about the Cas9 activator fusion protein? So this was actually a therapy that was based around Cas9. There are reports of anti-Cas9 antibodies. Is it possible that there's some innate immune response to that as well? So how do we prevent this from happening in trials as we go forward? For currently available delivery technology, that's AAVs, which is causing a lot of the immune problem here. The first is, can we reduce the dose as much as possible? As I mentioned, there were other patients that received high dose and actually did okay. So this may not be every patient that's at risk of this, but this is where we're seeing it, is in patients who are getting higher doses. Can we reduce that dose by using intracoronary delivery, for example? And then can we potentially use smaller payloads so that we don't have to give such high doses of AAV to actually get expression? We definitely need to maximize our interdisciplinary care for these trials. Certainly that patient had multiple experts on the panel, but as we're thinking about moving into phase 2 and expanding our patient population, we need to make sure that we have our transplant cardiologists who are, of course, expert at immune modulation in the myocardium. We need to make sure that we have our immunology colleagues on board. We need to make sure that we have hepatology because AAVs have some liver toxicity. And so I think that building that type of panel, a place like Stanford is really suited for that, right? We have experts across these diseases. And SCICD is one of the largest CV genetic centers in the country, which means that not only do we have the right environment to be able to do this safely, but we also have the patients who need it. So the last thing, and this is very important, is again that Goldilocks problem. Who is too sick and who is sick enough? And I think that that has to be a multidisciplinary decision along with the patient. Okay, so the other way that we can do this, which is coming and coming quickly, is to make skeletal muscle delivery and cardiac muscle delivery safer. So can we get away from AAVs, which have all of these sort of immune downstream effects, which require suppression of the immune system, towards something that isn't going to require as much of that? For example, LNPs, like are what are being used to target the liver. So the first thing we can do is we can try to engineer AAVs, not just for efficiency and tissue tropism, but actually can we engineer some that can escape the immune system? There are many people that are working on this, companies that have been founded on this, to try to use basically high throughput genetic manipulation in order to identify those that can escape these bad side effects. Others, Roger Hajar gave a great talk at our SCICD seminar a couple weeks ago about other ways to evade the immune system, and one is these commensal viruses that actually are identified in humans already. Can we actually re-engineer or repurpose them to infect the heart? Certainly targeted LNPs, Josh talked about this for the homozygous FH patient that can actually get to the tissue of interest. That's supposed to be a cardiomyocyte. And then lastly, can we make the necessary editing machinery smaller so that potentially we need to give less in order to get the impact that we want? So those are our next steps. We have to worry about off-target editing, make sure that we've got the right regulation for it. Josh showed you some great data, at least for the Verve technology, showing that they didn't have any significant SNPs that were induced across the genome. We need to define safe AAV doses and immunotherapy regimens and select our patients carefully, improve immunoevasive delivery, as we just talked about, and then make precise editing efficiency a reality, in particular in the heart. So with that, we want to say thank you so much. I think we have exactly 1 minute left for discussion, but we really appreciate your time today.